does it happen to? Well, it happens to probably somewhere between 60 to 80%, call it around 70% of patients with aneurysmal subarachnoid hemorrhage. It is, other than the aneurysm rupturing initially, it is, if you look at all the components, if you take, what would kill or disable a subarachnoid hemorrhage patient, if the initial rupture didn't, it's vasospasm. It's the leading cause of death and disability, as I say. The highest risk is somewhere in the as early as 3 days and as late as probably around 21 days. But in general, it peaks at around 7 or 8 days, and it can last upwards of maybe 11 or 12. And usually around then it trails off, as you kind of see here. So here's this blue line of vasospasm, and here's this red line of rebleeding. We talked about rebleeding probably the first lecture. Well, the rebleeding rate, once you've bled to begin with, you're probably about a 15% to maybe 17% risk of rebleeding in the first 24 hours. So that's what's going to kill you right away, and that's what we use Amicar for. After that, your risk of vasospasm goes higher and higher. So spasm peaks at around 7 to 9 days. Rebleeding kind of goes down at around 3 to 4 days. Now, the severity will really depend upon how much blood you have, as we'll talk about in a minute, and whether or not you've got collaterals, and there's another part of the brain that can take over. So, how do you predict vasospasm, or can you predict vasospasm? Well, you can. In general, the older you are, the less at risk you are for vasospasm. That's one of the slight benefits of getting older. If you're a woman, you're at a higher risk of vasospasm. If you're a young woman, you're at the highest risk of vasospasm. Young women are autonomically, among other things, autonomically revved. And their arteries are much more vasoreactive. So that's why you see women coming in more commonly than men with cardiac syndromes, the subendocardial injury, and with renal dysfunction and other kinds of things. If you've got a neurocardiogenic syndrome like neurogenic pulmonary edema, then you're going to have more likely to have vasospasm. Again, if you have hypomagnesemia, hyponatremia, hyperglycemia, you're more likely to have vasospasm. There are a couple of things that you can do to sort of look for it. One is the Fisher grade. The Fisher grade is how much blood is on the CAT scan on the initial rupture, because that's going to be a very kind of telltale sign that the more blood there, the more risk of vasospasm. And in general, a clot greater than 2 millimeters in any of the subarachnoid spaces, if you measure it, is an independent predictor of vasospasm. Hunt and Hess, as we talk about all the time, right? We always talk about Hunt and Hess. I went over this earlier on. There's Hunt and Hess 1 to Hunt and Hess 5, right? Hunt and Hess is a clinical indicator of the overall morbidity of a subarachnoid hemorrhage, but it doesn't predict vasospasm. The Fisher grade, the amount of blood, predicts vasospasm. CTA and CT perfusion predict vasospasm, and lots of other things as well. When I say the amount of blood, this is what I mean. So if you have blood right here in the Sylvian fissure, that's a telltale sign that you're going to have it. So the location, the volume, and the density, and the rate of clearance of that blood out of there are all related to the development of delayed vasospasm, which is why we put a ventriculostomy in, so we can clear that blood out, which is why sometimes we put intraventricular TPA in, so we can clear that blood out. The sooner you can get it out, the better. It's too early in the morning to talk about basic science, but there are lots of things, and I'm going to give a different lecture about this, but there are lots of things that go on to actually cause vasospasm. And at the end of the day, what causes them are something called, is it in here? Yes. Endothelin. So there are different types of endothelium. They're released at the vascular endothelial membrane. And if you look at a sample of artery, there's this constant yin-yang between vasodilation and vasoconstriction, always, in all of us, at any time of the day. Nitric oxide in general is the vasodilator, and endothelin is the vasoconstrictor. And when the balance or the ratio of vasoconstrictors and vasodilators are off, then you wind up with vasoconstriction, or I would say unopposed vasoconstriction. And that's what happens. So if you look at subarachnoid hemorrhage, your nitric oxide production goes way down and your endothelin goes way up. And there are other ways that you can overcome that. You can put a balloon in there and angioplasty it. You can put a vasodilator like a calcium channel blocker in there and open it up as they do downstairs or as we do upstairs. You can do lots of things. So how do we manage vasospasm in general? Well, we use calcium channel blockers. We do some variation on Triple H therapy. We use hypertonic saline. We use magnesium. We use statins. We do not use endothelin antagonists except experimentally because they're not approved by the FDA yet. We use intracisternal fibrinolysis, i.e. TPA, in the ventricular space. We use intracisternal vasodilators, which would be intrathecal nicardipine. We use intraarterial vasodilators downstairs in the angio suite. We use antiplatelet agents, which actually just decrease viscosity. And sometimes we use adrenergic antagonists. Which one of these work, or which in combination works, is actively debated. I can provide electronic copies of this to anybody who wants them. These are 4 terrific reviews of vasospasm and subarachnoid hemorrhage, more than I could ever say in 45 minutes, but they're really wonderful, and especially this one, the review of medical prevention of vasospasm after SAH, a problem of neurointensive care, which is what we all do. So it's great. It's a little older. It's 2001. Fortunately, not that much has changed. A little bit has changed, certainly, but it's a very good article. Just to dispel a couple of myths that go around, there have been 3 randomized trials looking at Triple H therapy. Triple H meaning hyperdynamic, meaning increased blood pressure, hypervolemic, meaning expanding plasma volume, flooding somebody with fluids, and hemodilution, which means to decrease the viscosity in terms of bring down the hemoglobin content. And there have been 2 meta-analyses of this data and all the other data. At the end of the day, this is what has been discovered. One is induced hypervolemia in a prophylactic way. In other words, you've got somebody who is awake and alert with a Fisher grade 3, Hunt and Hess grade 3 subarachnoid hemorrhage, and they're not clinically in vasospasm, as best you can tell, and they're at day 5. But you have a feeling that they're going to go into vasospasm, but you're not quite sure. It's not shown to be beneficial to prophylactically deliver hypervolemia. Euvolemia, yes. Prevent volume contraction, yes. But not to flood them with fluids, because it's clear that the cardiopulmonary complications far lead to neurologic and medical problems than benefits of prophylactic. So there's a greater harm in flooding somebody with fluid unnecessarily. The complications were much more common in the treatment groups than they were in the placebo groups in hypervolemia. The efficacy of induced hypertension and hemodilution really couldn't be shown. And there was no evidence of the for effectiveness of prophylactic hypervolemia and subarachnoid hemorrhage. So that's why you don't see us do it. We used to, probably 6-7 years ago, but not anymore. This is going to be a separate lecture on why we do or why we don't use PA catheters anymore, because for the most part we don't. But there are exceptions to this in cardiac patients, in cardiac thoracic surgery patients, but this is a very big review of the impact of PA catheters in critically ill patients. And at the end of the day, there's really no data to suggest that PA catheters actually, the information that you get from them, improve outcome. So is the catheter dead? Well, I don't know if it's dead, but it's not